Thanks, Martin, for this kind introduction, and thank you for having me here in Salzburg. It's a great honor to be here, and so I'm going to talk about vitiligo here. Just a picture of the center of Bordeaux, who will host the next ESDR meeting in 2019. So, what about vitiligo? Probably you know, so vitiligo is the most common depigmenting disorder, and vitiligo is often associated with very high impact on quality of life, and I will show you later. But despite being common, vitiligo has to date no effective treatments. So if you perform a skin biopsy in non-lesional skin, you can clearly find remaining melanocytes. But if you perform the skin biopsy on lesional skin, actually you can find disappearance of melanocytes. So the disappearance of melanocyte is a classical hallmark of vitiligo disease. So the prevalence of vitiligo worldwide is about 0.5 to 1%, raising up to 8% in some areas, such as India, probably to misdiagnosis with a chemical-induced vitiligo lesion. But actually, according to clinics, there is a lot of works made by the Vitiligo European Task Force to classify the disease. And there is different clinical subtypes. So the segmental vitiligo, that represents about 5% of the patients. And it often, so the segmental vitiligo occur on the segment of the disease respecting the middle line. It often begins in childhood, as rapid onset and stabilized, and then involved hair component soon after onset. And it's classically not associated with other autoimmune disease. The non-segmental vitiligo, which is the most common form of the disease, involved white patches all over the body. Can begin in childhood, but later onset is more common. It's progressive with recurrence, flare-up of the disease. And it involves a hair component in later stages. And it commonly occurs at sites sensitive to friction. I will talk to you about some environmental factors associated with vitiligo. So here is some clinical subtypes of non-segmental vitiligo. So we have the acrofacial pattern. The white patches involve the face, hands, and feet, and the general pattern with white patches involving the whole body. And we have also other rare clinical subtypes, such as the mucosal involvement, but also the mixed vitiligo, mixing segmental and non-segmental vitiligo. But actually, the problem in vitiligo, and thinking about treatment in vitiligo, is because vitiligo is considered today as a cosmetic disease. But clearly, we have to think differently because, okay, despite not being life-threatening, vitiligo is a serious disorder with major impact and social impact. And patients with vitiligo experience significant burden of the disease and self-perceived stress. And it was shown in studies that the impact of vitiligo on quality of life could be comparable to depression on some cancers. And patients are willing to pay a large amount of money to be treated. And it's really important to consider the treatment and the management of vitiligo. So vitiligo is a disease with high unmet needs because the current management of vitiligo is with actually off-label treatment and very old treatments. And according to the recent Cochrane database, there is no cure way of restricting the spread of the disease that have been reported so far. So what we are doing, we educate the patient. I will show you by avoiding some environmental factors, but I will show you later. The depigmentation is localized. We can use topical treatments, such as topical steroids or topical calcineurin inhibitors, associated with targeted UVB, such as excimer lights. If there is response, okay, we can carry on the treatments. If there is no response on the patient is still active, or the patient starts a wider spread depigmentation or very active progressive disease, you can start topical steroid, but also systemic steroid associated with UVB. For patients with no response on stable disease for almost 1 year, we can consider surgical treatments such as melanocyte epidermal graft. So as I show you here, it's very all treatments for treating vitiligo. So there is clearly need some new therapeutic targets in vitiligo. But thinking about new treatment in vitiligo, we have to understand better the pathogenesis of vitiligo. So, but just sometimes we get some success to treat our patients. And here is a patient with involvement of vitiligo on face. It's a picture on UV lights, and after 3 months of topical calcineurin inhibitor, you can clearly see almost complete repigmentation in this patient. So what about the pathogenesis of vitiligo? Vitiligo is a complex disease involving multiple combinatorial factors, such as environmental factors. We know that there is also intrinsèque abnormalities of melanocytes with increased defect of metabolism, but increased oxidative stress. But there is also large studies showing that vitiligo is considered as an autoimmune disease. Actually, there is a lot of work made by Richard Sprigg's group in Denver that shows that that genome-wide association studies has identified candidate genes related to the immune system. So the innate immune system, such as NAILP1 associated with the inflammasome, or IF3 or FIH1 associated with the type 1 interferon signal, and also genes associated with the adaptive immunities, such as the IL-2 receptor, MHC class 1 or 2. And vitiligo, again, could be considered as an autoimmune disease because all these genes that has been identified in vitiligo is also observed in other chronic disorders such as rheumatoid arthritis, type 1 diabetes, atopy, alopecia areata, confirming that we can find some association between vitiligo and this disease. But also, vitiligo is an autoimmune disease because actually with this simple observation that actually if you perform a skin biopsy in the perilesional skin in a patient with a progressive disease, actually you can clearly find T cells infiltrate closely to the remaining melanocyte and decrease of this T cells infiltration in the lesional skin. So how we can consider the first step of the disease? In a patient with a genetic predisposition and environmental triggers, and some have been identified, some sun damage, chemical damage, but the friction called the Kümner phenomenon, which is important in vitiligo. Here is a classical example of Kümner phenomenon in a young girl that with repetitive friction of the eyelids that develop white patches on this area. And these environmental triggers in a genetic predisposed patient can impact melanocyte that has been shown to be abnormal with intrinsèque abnormalities. A lot of works have been done by Mauro Picardo's group with increased oxidative stress, and melanocyte can respond by secreting danger signals such as heat shock protein 70, HMB1, calreticulin, or also produce chemokines and pro-inflammatory cytokines such as IL-6 or IL-1 beta. So, as I told you that genome-wide association study has identified some genes associated with protein of the immune system. A recent one has been identified. So it's IFIH1, which encode interferon-induced helicase C domain 1, which is associated with type 1 interferon signal. And a few years ago, we identified in patients with a progressive disease infiltration of cells called plasmacytoid dendritic cells in patients with active disease. And these cells are able to produce a large amount of type 1 interferon. And here you can clearly find expression of protein in the epidermis called MXA, which is a protein induced in response to type 1 interferon. And you can clearly find high expression of this protein in the perilesional skin, where in contrast, that totally disappear in the lesional skin, suggesting that the type 1 interferon is like a wave of inflammation following the progression of the disease. Next, we found that HSP70, which is a heat shock protein, which acts as a chaperone molecule, but under inflammation can act as a danger signal. We found that an increased expression of HSP70 in the epidermis of the patient with progressive disease, but also in patients with stable disease. And next, we found that there is infiltration of the plasmacytoid dendritic cells in patients with active disease in close proximity of the epidermal cells expressing HSP70. In vitro, we actually when we cultured plasmacytoid dendritic cells, we found that these cells can respond to TLR9 agonists to produce interferon alpha, but when we added HSP70 potentiates the production of interferon alpha by PDC in response to a TLR9 agonist. And then we found that interferon alpha is able to induce the production of chemochemical ligands such as CXL9 and 10 biokeratinocytes that has been also found important in vitiligo by John Harris' group. So now, what is the initial step of vitiligo? In patients with a predisposed genetic predispositions, environmental triggers can impact of both melanocytes and keratinocytes to induce the production of danger signal and chemokine ligands that induce the activation of dendritic cells, plasmacytoid cells, dendritic cells, to produce other pro-inflammatory cytokines and induce the secretion by keratinocyte of chemokine ligands, important for the activation and the recruitment of other T cells. But what about the adaptive immune response in vitiligo? Thinking about the adaptive immune response in vitiligo need to be put in the context of the recent concept of the skin immune surveillance associated with the involvement of the newly antigens experienced T cells called resident memory T cells. A lot of works have been done by Thomas Cooper and Rachel Clark groups in Boston to characterize these cells. And they found that these cells express CD103 and CD69, and they are very abundant in the skin. They are retained into the skin. They can proliferate locally and probably have long-life T cells and are associated with a first line of defense of the skin. But thinking about the presence of resident memory T cells in vitiligo is being suggested by this paper, because actually here is a paper in patient where the patient were follow-up of patients who achieved maximum repigmentation after UV light therapy. And in this patient, 44% of the patients develop vitiligo lesion on areas that have been repigmented by treatment after 1 year, suggesting that memory response can trigger recurrence of the disease at the same site. So we try to we isolate and extracted the T cells out of the skin in patients with vitiligo controls and psoriasis. And first we found that actually most T cells out of the skin, CD4 positive T cells or CD8 positive T cells express marker of effector memory T cells, CD45 arrow positive and CCR7 negative. And next, we clearly found here the example of on CD8 that the CD8 effector memory T cells express a resonancy marker in patients with active vitiligo, but strikingly, we could not find any difference between patients with active vitiligo compared to patients with stable vitiligo. Next, we confirm that by using immunofluorescence study on patient on skin, and clearly in patients with active vitiligo, we clearly found CD8 positive T cells, CD69 positive T cells, both in the epidermis and in the dermis. And we found double positive CD103 and CD69 both in the epidermis and in the dermis of patients with active vitiligo. But we clearly find some remaining CD69, CD103 T cells in patients with stable disease located in the epidermis compared to control disease and control healthy skin. And here is absolute count of the cells in multiple patients showing exactly the same results, so suggesting that there is a clearly role of resident memory CD8 positive T cell during disease flare-up, and vitiligo can be seen like a skin immune memory disease. Next, we check for other marker on these T cells. And we clearly found by immunofluorescence, here is CD4 and CD8, that there is a clear infiltration of CD8 expressing CXCR3 inside mainly in the epidermis for CD8 or in the dermis for CD4, and that these cells can be seen in patients with stable disease. And we actually next observe clear that almost all the CD8 positive T cells in vitiligo clearly express a CXCR3 marker compared to CD4 with lower expression of CXCR3. Here we found that the CD8 positive T cells expressing CXCR3 highly express CD69 and CD103. And next, using pentamer technology, we that can characterize melanocyte-specific T cells. We found that here in black is active patients, in gray stable patients, and we check for melanocyte antigen specific T cells against GP100, MART1, tyrosinase, and we found that actually melanocyte-specific T cells in patients with active disease are the cells, the T cell subsets that express CXCR3, and we found exactly the same thing in patients with stable disease, suggesting that the melanocyte-specific T cells are resident memory T cells expressing CXCR3. Next, about the function of these cells, we found that actually these cells, CD8 positive T cells, are able to produce large amount of pro-inflammatory cytokines such as interferon gamma or both interferon gamma and TNF alpha in patients with active disease, but low production of doesn't work. Try to. Don't know. Okay, great. With low expression of IL-17 compared to psoriasis CD8 positive T cells, which is a disease characterized by the Th17 response. I have some difficulties. Try to okay. And here, next, as I showed you during the postal work yesterday, that next we found that there is also another marker characterizing the CXCR3 positive T cells. So we check for the NKG2D, which is seen on cells, NK cells, NKT cells, but also on activated CD8 positive T cells. And we found that NKG2D positive T cells are within the CXR3 positive T cell subsets. I hope to do my best. Huh? I try to do my best, but I don't know if I need. There's maybe a problem of battery, but because I have no computers at the Okay, I will try to finish. I hope there is still some battery. But we found that actually next that these cells, these NKG2D T cells, produce also large amount of pro-inflammatory chemokine, interferon gamma, and TNF alpha compared to the NKG2D negative cells. Yeah, because actually I tried. Yeah, okay. Maybe I will carry on like that. Next, we check for the cytotoxicity of these cells, and so we check for expression of cytotoxic markers such as granzyme B, and strikingly, we found that the patient's T cells isolated from from active patients express granzyme B, but we could not find any difference between a patient with stable disease or controlled disease. So because of this result, we compare to T cells isolated from other chronic inflammatory skin disease, such as lupus, which is a much more inflammatory skin disease, showing high expression of granzyme B in the CD8 positive T cells isolated from this patients. And CD4 positive T cells express lower granzyme B. Next slide. Okay. For the overview of the pathogenesis of vitiligo, so I show you that under environmental triggers in the genetic predisposition, there is expression on secretion by keratinocytes and melanocytes of chemokine ligands and pro-inflammatory cytokines that induce activation of the innate immune system. Next, please. And that can activate the resident memory T cells that can proliferate locally, but also the chemokine ligands can induce the recruitment of new T cells from the blood to produce interferon gamma TNF alpha that can impact the melanocytes function. And in the lesional skin, you can probably, with the absence of melanocytes, you can clearly see presence of resident memory T cells. Next. Thank you very much. So we can think about new therapeutic targets, such as blocking HSP70, a strategy that is analyzed by Carolina Lepoul's group. You can also think about blocking the type 1 interferon signal. Of course, we can think about blocking the chemokine ligands, such as CXL9 or 10, or the receptor, CXR3, but also the use of a small molecule, JAK1 and 2, that can block the consequences of the interferon gamma action, but also the JAK1 and 3, because it could be really important for the maintenance of the resident memory T cells through IL-15. So just an example, because using tofacitinib is approved in United States for treating rheumatoid arthritis. And here is a retrospective study of 10 patients treated with tofacitinib. But not all patients responded well. But when you look on the patient who gets maximum response, the sites where that get response where the sites who get exposed to UV light, suggesting that probably in contrast to other chronic disease where you start an anti-inflammatory drug, in vitiligo you will probably need combination therapies. So first, blocking inflammation with new therapeutic targets, but also adding UV lights to induce the regeneration, migration of melanocytes from reservoir in hair follicle. But there is also a remaining question, because all I present you about the immune pathogenesis involved in vitiligo could be seen also in other chronic inflammatory disorder. But what is the specificity of this response in the loss, to explain the loss of melanocytes remain in question, in debate. It could be melanocyte destruction, as proposed by a mouse model of vitiligo, but also it could be also the detachment of melanocyte, an hypothesis proposed by Yvon Gauthier and confirmed by a recent paper made by Lionel Larue. And I hope to show you at the next AID very exciting result to answer this question. So I would like to thank my head of department, Professor Alain Taïeb, and here is our hospital in Bordeaux, and where we are running the vitiligo clinic. We are seeing most over than 1,000 patients each year. We are involved in a clinical trial in vitiligo, and I would like to thank my people involved in my lab. And here, Katia Boniface, who is my co-team leader, and she is sitting just here at the front row. And there is also Nesrine Boukedouni, a PhD student, Clément Jacquemin, postdoc, Christina Martin, PhD, Fabienne Luchez, Jérôme Rambert, Denis Thiola. I would like to thank the patients. So just above you have a communication paper from the French Association study. So it's written tattoos, hours are natural. And just here you have a book we have made for kids to explain the disease. So, and thanks a lot for your attention, and sorry for the technical problem.